Very good evening, one and all. Sir, good evening, sir. This is Vanilla from Hyderabad. Can you hear me, sir?
Yeah, good evening.
Yeah. Sir, I'll just make you the co-host so that you can share your slides yourself, sir. Sir, can we wait for 2-3 more minutes if you don't mind? Because like usually participants join between 8 and 8:05, or if the session was at 7, like they used to join it between 7 and 7:10. We'll just start the session in next 4-5 minutes, sir. 2-3 minutes. Yeah. Thank you, sir. I just made you the co-host and you can share your slides yourself, sir. Yeah.
Okay. Thank you.
So a gentle reminder to all the participants to please kindly mute your microphones, turn on your video cameras, and I think this is going to be our presentation. And if you have any doubt, like how to do a case presentation or like any questions during the presentation, you can always put them in the chat box or raise your hand. And your attendance is very, very important for us. And request, I see so many participants, irrespective of repeated reminders, like I don't know, for some unforeseen reasons, like participants have not been turning on their video cameras, but this is very important. Please keep your video cameras on. Good evening, Dr. Zanathan.
Hello.
Yes, sir. Hello. How are you, sir?
Doing okay. How's everybody tonight?
Yes, sir. Doing on well. I'm just a little doubtful because I saw an email from Dr. Gaushigan saying that he's doing the presentation, but I have sent him 2-3 emails, haven't received any confirmation after that. So,
okay.
So not sure like if is going to join or is going to present, because I haven't received any presentation ahead as well. So I received from this sir, the speaker. So I'm just wondering, sir, like in case, I don't know, if we don't get, maybe we may have to do only one today.
Sure. Yeah, and then we can spend some time just answering any other, if people have cases that have come up in the last week or anything, or the last couple of weeks, we can just answer questions if people have those, but or we can spend a little bit more time talking about this. So I'm easy either way. Why don't we get started with Dr. Nisahan?
I have here about 12 participants other than the faculty. So just waiting for 2 more minutes, sir.
2 more minutes?
2 minutes and then start. Just 2 minutes.
Sounds good.
It's 8:03, so we'll just start sharp at 8:05, sir, whoever is there.
How are things in Northern Province this week?
It's fairly okay now. The cases are coming down. The COVID cases are coming down, and but still we are getting some cases.
Yeah,
I think Vavonia is getting still not under control, but other part of northern provinces are fairly better in view of new cases. Even Vavonia new cases are coming down, but the cases of getting bad is a little bit more in Vavonia district. Otherwise, fairly okay. It's, I think, in the improving trend. And the lockdown is still going on until the 1st of October.
Okay.
It's a partial lockdown actually, so it's going on still.
Must be quite difficult for many people there with the lockdown, particularly people that can't work from home, like if they're more laborers or if they're more, in other work that's very difficult. It must, how does the government support people financially to survive?
Uh, now, the situation in Sri Lanka is somewhat different. Initially, they just gave some small amount, but
Okay.
I think this lockdown government is not in a position to give much of a
Yeah.
support.
Yeah.
So they are financially not much sound. But non-governmental organizations and the people who are here, who are a little bit of a well-off, trying to help, and for daily income jobs like labor jobs, who are doing some other labor jobs, they can go for work.
Okay.
And even construction site, there is no restriction for construction site, even for the last time even.
Okay.
So that's
Sorry
why-
to interrupt. Sir. So sorry to interrupt. It's 8:05. Shall we just proceed with the presentation, sir? So we have here Dr. Surain also and Dr. Vara, everyone joining us this evening. So it's 8:05 and good evening, everyone. This is Vinila from program coordinator from Hyderabad Center for Palliative Care. Today we have two presentations. So like fortunately, like not sure if the second speaker is still ready, but still we'll go ahead with the first speaker and then requesting all the participants to kindly please mute your microphones and a humble request to kindly turn on your video cameras and make them on throughout the session. And if you have any question, please kindly raise your hand. We'll always stop the session in between. And if you have any question, if you cannot speak, you can always type the question in the chat box and we'll read it out for you. And at the end of every session, like we'll be sharing the recorded YouTube link and the playlist. You can always go and read them like whenever you get time. Thank you so much. And over to you, sir. Dr. Jonathan, would you like to introduce the first speaker?
Sure. Well, good evening, everyone, and good morning from Canada. Good to see you again, and just getting a little updates about things there. And sounds like some things are starting to improve with COVID, but obviously still areas that are very difficult and ongoing, very difficult situations. So hope you're keeping well in a stressful time. This evening we have Dr. Nisahan, who maybe Dr. Nisahan should introduce himself better than I can, but he has a particular interest in palliative care and has done some previous training in that area. And he does try to incorporate into his current practice as much as possible, which is obviously more of a general practice, but he's one of the kind of new faculty members to join our group, and certainly I think will be a very strong resource for all of us in terms of what the palliative care needs are in Northern Province, and also how we can help some of these patients that face needs. So I'll hand it over to Dr. Nisahan, and I don't know if you have any other introductions you want to say for yourself.
Thank you very much. Good evening, everybody, and good morning, Dr. Jonathan. This is a case, an elderly lady with ascites, recurrent ascites. Actually, this is a case when I was working in DGH Mullaitivu. I was working in Mullaitivu as a consultant physician for 10.5 months, and then moved to Jaffna. So during that time, that's the first time I think in Mullaitivu history, the palliation was started. And we established 2-bed palliative beds for end of life care. And we started a lot of programs related to palliation. And luckily I was lucky enough to have a nursing support. There is a one and only community nurse. Even Jaffna does not have a community nurse. Only Mullaitivu had a community nurse, and another one was in Vaunia. So she used to help me in home visits. So actually, when I was there, I was almost practicing almost near normal palliation totally. Today, I wanted to discuss something about one of the scenario, one of the cases which have a little bit of a mm, tough in case of communication-wise. Elderly lady with ascites. The background picture, what I have put it is actually the Madavasa Singam Kulam, which is around 10 kilometers from the DGH, and that is a spilling over time. It's a very beautiful area. The nature-wise, I didn't see such beautiful area in Sri Lanka. Maybe New Zealand is good. Other than that, I have seen this is, I think, in the near to the November, December time, rainy season, this sort of beautiness you can see in the Mullaitivu, the nature. Okay, with that, we'll move into the case discussion. So what's the thing I wanted to highlight here is how to handle the relative expectations in our community with ethical concepts. So that is a major challenging in the northern province as well as mostly in the Asian population. We have seen this sort of ethical to practice the real ethics is a little bit of a difficult. So I will just go into that in detail when I am discussing the case. And other one is very poor, very challenging to practice an end of life care in a poor resource setting. That is, we have make it little bit meaningful, but you know, so I think until 2013, when the Hyderabad team came here and did some lectures, the palliation is not that much practiced at all. But when you started to practice the palliation, then some people might think they are doing euthanasia. Still, that concept is a little bit of a difficult to handle in our area. So we'll move to the case discussion. So this is actually, I have changed the templates of the things according to my things to make up a little bit of a more of a story sort of things, but most of the information what you want it is will become in an order. So this is an 88-year-old lady who is actually diagnosed to have carcinoma of unknown primary. Is it clear? Oh. Yeah. So is it everybody can hear it?
Yes, yes, sir.
Okay. So it was actually referred by the oncology team of Tellipalai to follow this patient for carcinoma of unknown primary with metastasis. But previously she was quite healthy. She's not on any drugs or anything. So how the diagnosis came is actually she is previously healthy, and actual referral is only for repeated paracentesis. That is, they have decided for symptomatic treatment, the relatives and the patient and the oncology team, and they send it for repeated paracentesis for symptomatic relief. The patient's sister's son is a consultant radiologist. He is actually known to me for a long time from my medical school. When before actually her history started, it's just before 2 weeks, they have brought the patient to the Jaffna because of generalized functional decline and loss of appetite and loss of weight. And they did a scan and the basic test. They found to have a liver metastasis and ascites on ultrasound. And family members not willing for further evaluation considering her age, and did a therapeutic paracentesis 2 times in the private sector in Jaffna. And most of the investigations were normal, except a mild hypoproteinemia. There are some spelling mistakes. Sorry for that. I did it very quite fastly today only. She is not on any drugs except for vitamin B or some vitamins only. She is actually not in pain at the moment when I'm assessing, and only feeling discomfort due to the that fluid in the tummy, and not even taking a paracetamol for pain. BMI is 16, that indicates is quite very thin build, and there is no headache or generalized weakness. Generalized weakness is present with the wasting of the muscles are present, but she could be able to sit up and walk with the support. There is no shortness of breath at rest, and when exertion, having some mild shortness of breath. That means when they are taking to the bathroom, she had some mild shortness of breath. but she is using with the support only. So most of the time in the bed for the last 1 month. So the actual history, she become to the most of the time in the bed for the last 1 month. But otherwise, on examination, ascites is present. It's not tense ascites, no angioedema, and cardiovascular normal. Bowel habits is every other day. That's a usual one. And urination is okay. Sleep is good. Appetite is poor. And communication-wise, it's limited. She's answering appropriately when I ask questions, targeted questions. Maybe it may be habitual, or I thought there may be a part of early dementia. I couldn't assess the MMSC because it's quite difficult to say. But when asking a question, she is answering appropriately, and she is quite confident in what she wants really. So actually, she is having a good family support, living with a daughter and the grandchildren, and just 5-6 kilometers from the hospital. But patient does not know about illness. What is going on is she didn't know about that. Nobody just not informed. But quite worried about the fluid in the stomach. But she accepted her general decline over the last month. She is not able to do her day-to-day activities much by her own. But what's her expectation from us is mainly wanted to tap the fluid, and then she wanted to go home, because this is a lady who has never come to the hospital at all. Right? She's quite healthy for a long time, so she don't want to stay at the hospital. The family concerned, her daughter who is looking after her, it's also the same. So they does not want to break the bad news to the patient. So what they said was, patient can't tolerate that, and we know better about our mother. If she knows that it's a cancer, then she will be worry more. And they wanted a regular tap for the ascites anyway, which I don't convince much, because it's not a tense ascites. And she is not shortness of breath. There is no proper indication. So, but what I did was, so she is actually following Hinduism, and except the special days, she's not following anything. There is no special concern from the spiritual point of view, but they just wanted mainly a comfort care mainly. That's all. Dietary prevention is also not much there. She can eat a non-veg and veg, but last 1 month the diet habit is very poor because of the loss of appetite. So what we did was, on patient demand, I did a peritoneal tap with albumin infusion in the first instance, only just 700 ml removed because it stopped after that. We educated about the tap, and which is not necessary. I educated and started with a low dose of diuretics to counteract this one. And advice for the hospital admission when you have to admit and those stuff, and then we refer to the community nurse, because at that moment she does not want any sort of a pain relief or any shortness of breath except for support. But at the last part, I try to explain to the patient regarding the disease, but she does not wanted to listen much on that, but she wanted at last is to remove the fluid. Maybe she's not enough understanding with me, or maybe a part of a dementia was the thought. In 2 weeks time, again readmitted for ascites tap. Again, the consultant requested for the tap. He's actually working far away, but they wanted to tap it again. But again, I did the tap, and then diuretic, I adjusted it for a symptomatic one. Then she was all right. And the community nurse on and off informing me about the patient when she is having a visit every week or every other week, she is going and visiting. But after 1 hour, or else if they call it, then she go and visit. Usually that's the pattern there. So after 1.5 months, again readmitted with difficulty in swallowing, mainly for the solid food, but she can drink water. And chest pain while swallowing. So, but they don't want to go for an OGD because it will hurt her mother, and she is also not willing to go for any procedures. So there was some oral thrust was noted. So with that, I treated with nystatin for this thinking about candidiasis. Blind treatment started, and within 2 days she felt better, and she can able to take some more solid foods and semi-solid foods. She could able to take it and discharged. So as the family members already knows the prognosis and all the relatives visited her, and patient was happy about that. I inquired about their relatives who have visited recently. He remembered some of them, but some of them she could not able to recall it. Even the relatives who are not that much frequently visiting, she is not remembering much according to the daughter. So community nurse further mentioned, then after the review, then she's intake is coming down and down. Again, we advise for conservative approach only, and liquid diet continued. Then after some time, then altogether, I think now around 3 to 4 months gone, then they're readmitted in 2 weeks time with a chest pain worsening with the drinking of water even. But there was some rest pain was there. Rest pain, she is mentioning about 4 out of 10. Then as she can't take much oral drug, so I consider for fentanyl patch with some amount of lactulose. And again, she said she's better, she wanted to go, then we discharged the next day. So meantime, the committee nurse will go and change the patches. So another every third day, she go and change the patch. Another 2 weeks time, she wanted to actually see me. So I was the one and only physician there. So throughout on call 24/7, only I'm coming home at weekends. So Sunday they call me, the patient wanted to see you through the consultant. So I said, okay, I'm coming on Monday. They can admit today even. Then I can get an input about the patient. But he didn't turn over, but he came on the next day, Monday. So complaining of multiple body ache, the relatives requesting a saline because she is not drinking much for the last 2 days. She couldn't able to drink, nothing is going inside. So they were quite worried about that part. But the patient is not mentioning his thirst. But she wants a pain relief only. And sleep also disturbed. So throughout these days, her sleep is quite good. But this is the first time he's complaining mainly about the sleep. He couldn't able to sleep. So that indicates he's in pain mostly. He couldn't able to elaborate that. So initially subcut morphine was given, and the condition he couldn't able to much sit up even in the bed. So we plan to go for an end of life care after discussion with the relatives, and I informed the patient also, I will make you comfortable. So again, we planned for the isolation room. Luckily, there were 2 beds. There is nobody that day. So we give it 2 family members to accompany that because they have to look after the bedbound patient. So after the first time tap, this is the first time we put the needle because subcutaneous morphine, I couldn't able to give continuous. I don't have a setup there. And family members, even though I explained saline is not going to work much and she's not in a thirst or something, but they were quite worried about that. You know, in our people might know it for Dr. Jonathan, our people had a palliation in the ancient time by pouring the milk into the mouth when the patient is gasping or something. That sort of palliation may be in India too, I don't know, but it should be acquired from there, from India. But how the message was transferred and it was followed up is actually they might be in a thirst and they might be in something, and you have to give it at the last point. Then only the soul will depart nicely. That was the message. It was passed to the community. So still in the rural areas, they pour the milk into the mouth, and actually why they pour the milk is to aspirate and die. Right, so that is the aim. And I know some of the religion in Muslim, this is Hindus practice mainly. The Muslim practice, some people put the sand into the mouth and then they will aspirate and die. So, but what was happened was if you are not giving some fluid, then they might quite upset because even though the family members are not that much educated, they are doing small jobs and they are self-satisfied with their farming things. So they are quite worried at the last part. Usually we give some fluid and those stuff. Otherwise, the soul might not be happy. So that was the aim. So I decided not to confront because this is the first time we are practicing and know that most of the people know the Mullaitivu situation of what's the community expectation. They might think this is a euthanasia practicing. So I give some IV fluids. Saline, and then meantime I practiced. So I have palliation. So what I did was I put the IV cannula, and then you don't need to prick every time, even subcutaneous, I don't need to prick it. So I use the cannula for that purpose. So this is the first time I prick it after the tap, and started with haloperidol and midazolam and morphine also every 2 hourly as a sit and give it. So that's the way we usually give it. So the patient journey actually safely landed without any shakes in the next day. And relatives thank the hospital staff with the preparation for the funeral on the same day because they are already expecting that part. So it's actually a safe landing. So what as a physician, my main concern was is really the end of life care is not ideal because even though I am staying inside the hospital that time, all the times, but I can only visit usually around 8 p.m. to look after. So in a poor resource setting, maybe mid of the night, nurses won't go and assess every 2 hours. It's not, even though they said they can do it, but it's quite difficult for them. But what I do is I tell the bystander, the relatives, the daughter, if she is moving here and there, or if she is grimacing the face, just inform the nurse, and they will come and help you. So this is how I practice it. Because the nurses is not one-to-one care. The night, the nurses will be one fellow for 20 patients, 20, 25 patients. So it's quite difficult for them to follow it. And doctors also quite busy because they are the one doctor for the total medical side, only one doctor will cover it. So the next main problem is the practice of ethics. It's very unfortunate to not to tell the patient that you have a cancer, but luckily in this patient he is already prepared for that. He don't have any sort of outside businesses to complete, but still she's not prepared much unless she understands she's going down. So what is the main problem for me is actually in my mind setting, it's there is a war whether am I doing a correct thing for a last part of a patient, or am I practicing out of way? The people does not understand the ethics is also is made for to get some sort of a benefit to the patient, but it's actually a little bit of a war between my mind. But actually in this patient I was then settled within my mind because the memory is poor, but so I can't able to inform fully and she can't able to retain. So I make up my mind a little bit in out of the way. But main strength in this patient is actually the good family support. This is the one of the thing I would always appreciate. Even when I was working in Australia, the palliation is at the community level is very good, but the patients are not that much happy. Those who are previously with the family, then gone for a hospice care. So here in the Sri Lankan community and in the Asian community, the family support is very good. But it's as usual, is westernization is happening. So nowadays, most of the parents are left alone. So even the community nurse mentioned in her surprise visit, even the nursing care was perfect, and there is the family members are quite giving a good support. So that's the main strength of in this case actually. I think that's all. Any questions and any other things? So just what I wanted to ask from Dr. Jonathan and any other specialist in this palliation, is there the better way you can cope with this sort of ethical point of view? If a patient's relatives are telling not to break the bad news, Because what I do is for other patients, I just take my own path and I just inform halfway, step by step. Because if they can understand, then that's actually a better outcome I have seen with my patients even. But for these sort of patients, it's actually, he's halfway, he can't able to retain the memory. So in that case, that's fine. We have to follow the relatives. Okay, thank you very much. I think that's the end of the thing. So this is not the same pond. This is the other side of the Mullaitivu, that's Malawi area, the same time, almost at the same time, rainy season. Again, it's, but actually speaking, this is a lockdown time. There are how many of people are actually enjoying this thing. So this is how the lockdown is also going in Sri Lanka. Now, this part is quite worse nowadays. Okay, thank you very much.
Thanks very much,
Thank
Dr.
you.
Nisahan. Anybody
Sorry,
have any
Nisahan, I have a
Oh.
quick question. What was the fentanyl dosage you were using?
I used initially the 25 microgram patches we have it. So I
Okay.
used 25 microgram patches, and then 50 microgram patches also we are having with us.
So before fentanyl, I mean, I may have missed it. Did you use any narcotics like morphine or before you switched to fentanyl?
No, in this case, what was the real problem for me was she couldn't able to take tablets by her mouth. I started the fentanyl in her when she come with a difficulty in swallowing.
Okay,
So,
but you didn't use any narcotic before the fentanyl, right?
Usually I go for morphine.
But
always.
this case, you didn't use anything.
No, in this case I didn't do it. I directly go for the fentanyl because
Okay.
the thing is she can't able to swallow the tablet. So I wanted to give a patch. I wanted to discharge the patient as well. In the meantime, she's not willing to stay most of the time.
Yeah. Okay. No. Just a question. Yes, Jonathan. Yes.
Yeah, it's a good point, Vera. I mean, normally when we're using fentanyl patches, we think of we can't use them on people that are opioid naive. So we usually like to have people having at least some opioid tolerance before we apply them, just to make sure that they'll not have any bad side effects. I'm glad it sounds like she tolerated it okay, and it was quite helpful. So that's good. I guess just you have to be careful to watch out for that and make sure that patients know what, and family members more importantly know what side effects to watch out for. There is now in some places the 12 microgram patch available as well. That's a lower dose. So I don't know if you could talk with your pharmacists about if there's any way of getting access to that, because it can be quite helpful actually for starting at a lower dose for people that are very sensitive, as well as when you have to adjust the dose moving forward. It's nice to have a bit of a smaller increment sometimes. And sometimes for people that are extremely frail and opioid sensitive, or they have very bad kidney disease, we actually even do use half of a 12 microgram patch. We just cover it over with a occlusive dressing, the other half, because it seems to be the best opioid for people to tolerate if they have bad renal failure and morphine's accumulating and that kind of thing and causing toxicity. So fentanyl patches are, as you mentioned, extremely helpful for people that can't swallow very well. But yeah, usually we would suggest, and the manufacturers would suggest, having some opioid tolerance before starting them. So anybody else have any comments or questions about that case? Or there's lots of medicine and ethics and communication and stuff to unpack there.
Dr. Nisahan, that was a very excellent presentation you made just now. And even here, I mean, I work in north of Toronto, so we have, I work with mostly the Caucasian population, the Canadian, but I have few Sri Lankan Tamils who have moved from Jaffna to living in Toronto, and same issues we have, saying don't tell my mother the diagnosis. Let's treat her and happy till her die. But I mean, here we cannot do that, and we have to sit and explain. Of course, we are very much gifted with the social workers and all the support staff. I think there is no one straight answer for this question, but I think there is more community awareness needs to be done, more talks and community awareness needs to be done. Second thing is the family meeting and explaining to the, I know everybody is busy, especially in Sri Lanka with so much shortage and so much, a lot of stressful working environment by the doctors and nurses. I think it's taking time to explain to the relatives and the patients and why it's important for the patients to know the diagnosis and what's the prognosis. I think open discussion is one of the solution. It's easy to say from here, but you know how difficult it is in Sri Lanka. I think you're muted, Dr. Nisahan. You're muted.
Okay. Can you hear? Yeah.
Yes.
Yeah, that's the main thing. Coming back to the previous Dr. Jonathan things, actually, fentanyl patch, we have only 25 and 50 is the government is getting it, and we can't get it in the private sector. It's quite strict on these narcotic things in Sri Lanka. When I was searching for this fentanyl, actually, only place I got it in Maharagama, they have it. And some of the patches, they have it in Jeff now. Then finally, with our pharmacist help, after I go there, I got some 50 patches. And what I heard was surgeons previously used, they cut the patch to half and use the 25. But I was not convinced with that. But finally, I got some 25 patches. Nowadays, for in BH kites, I have 25 patches. Because 25 to make it 50 is quite easy. I can put a 2 patch. This is quite risky for me. But I didn't know that there can be, you can put something the halfway and put it there. Thank you for that knowledge. Then we can try it if we are out of stock of 25.
Cutting is very dangerous because it can release the whole thing at one shot. But what they do here is that I've seen the nurses doing it. They actually cover half the patch with a tape or something and apply that, and then use the other half after 3 days. I don't know. Jonathan is a best person to explain that.
Yeah, I mean, it basically the dose of fentanyl that the patient receives is proportional to the surface area of the patch that's touching the skin. So theoretically, if you occlude half of it, then you should be delivering around half of the dose. Obviously, this is not precise, so there is some risk of inaccurate dosing. With cutting them, it used to be a big concern because the way the patches were made, all the medication could kind of leak out very suddenly and cause an overdose. Some of the newer patches, I'm not sure exactly which types you're getting there, but some of them are in a different form where the medication is more impregnated into the patch itself. So when you cut it, it is theoretically safe to do that and apply it. Now, the manufacturer will always say that cutting them is bad and it's off label. But I guess it's just whatever you think is less likely to be of risk. But yeah, in our practice for needing to use half patches is to just occlude it with a occlusive adherent dressing and then have only half of the patch. I probably wouldn't, like once you've used it for 3 days, I probably wouldn't reuse the patch necessarily because the dosing is a bit uncertain at that point where you actually are. It's also important to remember that when a patch is finished after 3 days, there's still actually quite a bit of medication in the patch. And so they do need to be disposed of properly. You don't want like a animal or a child or something eating them or something. But they are very, very effective. I will say with the 12 microgram patches now, it's quite nice. We don't have to do the half patches so much because the 12 microgram increment is small enough to be able to just do it with that. But
Thank you very much, Dr. Jonathan.
Yeah.
So what about, in that case, you start the patches as outpatient. Usually what I do is I keep it at least for 1 or 2 days and then assess it and send it, because or else if they are on opiate, you can go for an opiate calculator and change the doses. If they are, you are first time starting, say if the patient is on a CKD, the chronic kidney disease, and you want to start in a either fentanyl. So in that case, you just start it and send them home, or just observe for 1 or 2 days.
Usually people are already on another type of opioid. So like for people with kidney disease, often we have them on either hydromorphone or oxycodone type of opioid that is a little bit less toxic in renal failure. I don't think you have access to hydromorphone and then no oxycodone there either, eh? Yeah. So yeah, I have never started a patch on somebody that's not on opioids already, because they always tell us very specifically in medical school not to do that. So I can't really comment on that, but it sounds like it works reasonably okay there. So I'm glad to hear that.
So, Dr. Nisahan, I work in Ontario. So here the strict guidelines is, if you want, before you start the fentanyl patch, you have to have first tried the short-acting morphine equivalent, and then you should have tried a long-acting equivalent, like a controlled release one. Then only the pharmacist will release the fentanyl patch. Otherwise, if you don't try that controlled release, they won't even release it. So that's the very strict guidelines here. But I know it's in Sri Lanka. It's I mean, you have no other choice there.
Yeah, even in Australia, we directly start a fentanyl patch in a CK renal impairment patients. The pharmacist will allow for that. Even IV, we can start it there. So that part is there. We don't have oxycodone or hydromorphone, even buprenorphine, nothing was there. We have in a narcotic side tramadol, and then the morphine. Fentanyl even actually came into the Sri Lankan practice for when I was leaving Australia in 2018. It was not there here. I think it's around 2018 to 19 only we got the fentanyl patch a little bit available. And what I actually learned here is people here in Sri Lanka is a little bit afraid to start or use the morphine because of, as you mentioned, the medical school teaching. We are quite afraid. But when I go on there in Australia, the nurses will come behind and write it, doctor, you write oxycodone PRN. Otherwise, we can't manage the patient in the middle of the night. And oxycodone endone, the train name is endone. So all the charts will be behind that will be endone, or targin will be there. Even targin is not available. That is a little bit of a safety. So they always come behind and write, unless otherwise they will call again and you have to go and write it. But when so here usually we practice this part only for a very bad patients. And in my practice, what I do is even in CKD patients, if they are going towards the end of life, I change over from fentanyl to morphine to get the more euphoric effect of morphine. Is that the practice you practice there in Western as well? If they are going for end of life, if they are on fentanyl for some other reason like chronic kidney disease, would you change over to morphine?
Usually not. Usually we would keep them on fentanyl with because switching them over to morphine, just worry about contributing more to opioid toxicity. So myoclonus and seizure risk and that kind of thing. So we usually would carry on with fentanyl and delirium and that kind of thing. So
I think we have a suggestion from Hyderabad, whether we could go for the next presentation and have the discussion at the end of the thing. Is that okay, Jonathan?
Yeah. Sorry, I thought there is nobody to present. Sorry.
No, that's okay. I'm just wondering, Gaushikan, we are kind of running along with time today. And it seems like there's good things to discuss with this case.
Yeah.
Gaushigan, would you want to present your case maybe next week?
Yeah,
we
I
have
can
pro-
present it next week. Yeah.
So we have proper amount of time to discuss things and we're not so rushed. Is that good?
Yeah, sure.
Okay.
Yeah, that
that's
is good idea, Jonathan.
Yeah.
I think that maybe one case, if you can
Yeah.
present like this, maybe enough. No?
I think that's good with enough discussion. So what do people think about the some of the ethical questions that were talked about in terms of disclosing diagnosis and prognosis to patients? Is that something you encounter commonly in your practice? How do you manage that with families and patients? It'd be really nice to hear from any of the other participants.
Yeah. So I think that the participants' contribution is very important, and then learning.
When you have families that are saying that they really don't want their family member to be aware of their prognosis, and telling you not to be truthful with them, how do you manage those situations?
What do you think this Nisahan, your point of view, that for our setting, if you have a good hospices, is it okay? Why that you were telling that to monitor midnight 2 hourly is a problem?
Yes, yes and no. The thing is, if the hospices can give a full supportive care and they are trained nurses, then that would be fine. The most important thing is practicing end of life care out of hospital is a little bit of a difficult for us. I know in foreign countries they start the syringe drivers even at home, and then they can able to manage that part. And even in Australia, they brought it for the end of life care to the hospital. The problem is assessing in a later part of whether the patient is in pain is only by shuttle changes. And if a doctor visiting or if a consultant able to visit and see it, that would be better. But for otherwise, for starting a thing and then starting a drug, and if they can assess for the particular side effects and inform, and if the naloxone is available with them to reverse the things, and say oxygen is available in the hospices, then that would be fine. That can be considered. And the hospital distance to the hospice is nearby, then that would be fine. I think like a hospice like a care can give a little bit of a better thing because they are quite experienced in that. Yes, in that way it's all right. But you know, the main problem here in northern part, I don't know about the other part. When you start the term called palliation, people will say that they are trying to kill it. So even some of the doctors have that attitude. So they won't say anything, but they will start to whisper among themselves. Now that they are planning to kill. So that sort of things need to be started. I think the palliation should be at least introduced at the level of university level. I didn't have a chance to get the introduction of palliation at university level. I got it when I was a registrar only. That's also luckily the Hyderabad team came. I think Dr. Shwendra Umar was there. I was in part of a Jaffna Medical Association. So that was the main challenging. What I felt was it's quite easy to manage the public because if you sit down and spend half an hour to 45 minutes or 1 hour time and explaining what will be happening in a proper way of communication, I have enough patient and cases also with me. So they finally come out with a good thing, a good understanding, and they were quite happy that they got to know that and they prepare the test. But it's quite difficult when the doctors are relatives, or if a doctor is involving doctor coming as a patient, it's quite difficult. And you know, in our part, if there's a patient, then there will be 2 or 3 doctors will call and ask about the patient. Somehow they find some of the part to catch a doctor, known to this man, known to that man. It's not like a foreign countries. The foreign countries, nobody can. Even when you start end of life care, even they can't just come visit and see the patient frequently. Only the visiting hours they can come. But what I do here is obviously on the other way. If there's a started of end of life, I usually not restrict the patient, restrict the relatives to come. They can come at any time and see. Even in the middle of the night, I tell them to see the patient, because that's quite, they will be get some sort of a traumatic thing. So this may be considered as part of the public is not public, and our mentality is not giving value for the death, value for what they had it in the past. Maybe considered as that. But it is perceived in the public, we have to try to the maximum to safeguard. We have lost enough people in the war, so we have to try maximum to the part, but nothing worry about this outcome, but we have to try for it. So, so that's a part that was initial thought. Now it's gradually little by little changing, but I don't think the proper palliation is not up to the standard. Even within the hospital, it's very difficult to practice. But if you are ready to, as a physician, if you are ready to spend a 1 hour time with the patient and relative, yes, that's possible. The only thing is doctor-patient ratio is quite high. One doctor, one physician is looking after too many patients. On a day, usually casualty days, they see around 60, 70, 80 patients. So that's quite difficult to manage.
Mm-hmm.
So that's, I think it will take some time. It's a good start, good thing. I think in 2015 or 14 we started. It's slightly going up and up, I think. Now most of the physicians, young physicians, are happy to practice. So that's, I think, good sign, and hope we will come to the standard gradually.
Yeah, and actually, I am 2 weeks back, National Cancer Control Program invited all the faculties. So in fact, that they have shared the minutes today. They were actually asking the level of teaching, undergraduate teaching at medical schools, and different universities having kind of different levels of teaching, but not very kind of a comprehensive plan one. So then they want to introduce now kind of the basic fundamental things that should be incorporated in the medical curriculum, and then take this leadership thing. So as you said that gradually in Sri Lanka, you know, even this concept is very new. So after 2010, in Sri Lanka, people started to talk about palliation. So in the last few years, things are moving in right direction. So even that we have now 2019 only, we have developed the palliative strategic plan, and then still we are struggling to find out medical services. Yeah.
Hope, I think I will get a good palliation at the latter part of my life. That's my aim. Nothing.
I think that
because the way it's moving, it's not sound good at the moment. I think Jaffna we could able to do it, but I don't know about the other part of the province whether they can reach it at the standard or not. Because now we have, I have incorporated most of the base hospitals to start practicing it. Maybe in 20 years we might go for a full extent. I think. Hope with the support of people, it might we will achieve that.
Yeah, we got this right-minded physicians to work. Then as you said, then there are a couple of, but we need to encourage them to join in a group, and then also we got good support, then good faculty, and particularly PWCC, IMHO Canada, and all, even IMHO USA also committed to implement this, and there are other people. So if we can keep this momentum, then there are young doctors and nurses at the moment. We are also getting, and we train these more and more people, and people will aware. And then maybe in a couple of years, it will become like an acceptable thing, and people will start to realize the importance of palliative care.
I think that was really great, Dr. Nisahan, to just identify some of the barriers that exist to palliative care moving forward, and a lot of your settings. Some of them are big practical barriers that will be difficult to overcome and will take more time, like not having enough nurses, not having enough doctors, some of the medication access and things like that. I think some of the culture and values that you talked about in terms of, you know, even physicians being scared to talk about dying or feeling like it's euthanasia basically to be transitioning to a palliative approach to patients. And I think those are things that are very changeable in a shorter period of time. At least more and more of us that can be aware of these issues and talking about them and talking more openly about them. I mean, obviously, it takes a long time to change professional attitudes. And even in Canada, where palliative care has been talked about for some decades, there's certainly many parts of the medical profession that it's a bit of a taboo topic to talk about, but it is becoming more and more open to talk about amongst the medical profession. And I think society starts to get more aware of the issues as well. And so death is a part of all of our lives. And I think all of us would hope for ourselves and would hope for our family members to be able to have as comfortable and as meaningful an end of life experience as possible. And so I think that is really what motivates us moving forward. So really good identifying though of some of those challenges. And I guess I also just wanted to encourage you that, you know, some of this does take a lot of time, as you mentioned, with patients. I think particularly in the, you know, last days to weeks of life, often the nursing care component is quite heavy, and just some of the physical care needs and that kind of thing. And family can be very helpful in supporting that. But even for physicians, you know, even if they're brief interactions, I think they can be very powerful and meaningful interactions with patients and families and helping them to cope and to understand what's going on. So you can be effective even with brief interactions, as long as, you know, your mindset is open to where the patient's at and helping them through that. So we are starting to get a little close to the end of the time. Just in terms of that question around how people manage with patients or with family members that don't want to speak with or don't want their family member to know kind of the truth around their diagnosis or their prognosis. Any of the participants have any comments about that at all in their practice? Maybe if nobody's going to volunteer, I can just start calling out some names so that we have some participation.
We have to do this for every session, sir, because we
Okay.
are a very, very quiet group.
Okay.
So
how about, let's see, who's first on my list here? Dr. Jude, any thoughts on if you've encountered that in your practice, how you've managed that? This is not about right or wrong answers. It's just about sharing experiences. So. Oh, is there
someone raising
somebody's
hand? Yeah.
one raising hand? Oh yeah.
Yeah.
If you're raising your hand, then Dr. Vithurin. Okay, yes, you go for it.
Thank you. Thanks for the great case presentation, sir. I have a small doubt to Dr. Nisahan, just to clarify. How can we incorporate with the physicians and the trained palliative care medical officers or someone? Because at the moment, we don't have consultant palliative care physicians in Sri Lanka. And diploma holders, I think nearly 4 or 5 batches are under training, and some of them are left the training and not in the field as well. Some of them are in different fields. We don't have a proper setup, whether after the PG training, whether these diploma holders or maybe MSc holders should be in the field or not. So in such case, considering the northern region following this course, how can they be incorporated, or how can they used for this palliative care chapters in our setup in northern region?
That's a good question. What actually speaking is, unless our health ministry have a particular system of appointing for medical officer palliation, it won't going to happen. So as you know, there are some psychiatric medical officer like that, each and everything, or more medicine like that. If they are going to appoint at one point MO palliation, so until such time, the people who are interested should be practiced, or else it should be seen by the medical team. So initially, I was also quite a dilemma in this area because how it's going to be practiced. But when I went to Australia for overseas training, there are in big hospitals, they have the palliative team, particularly palliative consultant and those stuff. But small areas, though, they have the palliation should be practiced by the medical team. And if they want, they can get a distant consultant opinion. So this will be the case when the consultant palliation officer is going to be released at one point in Sri Lanka. Now they are going to start the PG training for consultants. So that time, if they have a doubt, somebody from the doubt, then they can call the nearby consultant and ask and go ahead. So as a medical team is always there in the hospital, so they have to look after. That's my opinion, because they are better in assessing and those stuff. So the people who are trained and who are interested, like the other things, say, now in our setup, if you are appointed as a MO blood bank and you wanted to do a surgery, really, you can talk with the surgeons and you can practice help in the theater. There is no harm in that. So the same way the palliation can be practiced if somebody is interested. But otherwise, I think the medical team has to take over totally until the palliative team is appointed and do the stuff. Still, it will be start from the beginning, from in national hospital, then teaching hospitals, appointment, and then the district general hospital. Maybe I will be retired before that, probably, because it will take a long process. Even still, you know that Mullaitivu is suffering to get the consultants in the major fields even. So that will be the result. So I think if they try to introduce some of the part, and the problem is, I think the physician training, if they try to incorporate some of the things, then that would be better. But as the PGIM, now what they do is, our postgraduate training is they wanted to keep it as a different arm. So they are trying to establish that one. Hope, I think, as Dr. Jonathan said, if you started some of the more and more lectures and more introduction and more courses, then we will upgrade ourselves to a certain point, I think. Did I answer your question, Viduran?
Yes, sir. Thank you. Thank you so much. In a way, my small worries, because we have been introduced to this new chapter, the palliation, and we are planning to initiate in the northern region under the PD's advice and with the cooperation of Hyderabad team and great experts. But when we are not going to practice, or when we are not going to apply it in our hospital setups, then again, that will be like having a diploma or MSc and working in some other chapters like surgery, diploma in chest precision, diploma in chest medicine, working in the surgical unit or in the blood bank. So my worries, or my thinking is like how we are going to apply in our setup, or how we are going to keep the knowledge by this training, which is applicable. How are we going to apply with the setup, the health setup? That's what I worry, because in Jaffna we are having teleplay oncology unit, and we have Vaunia also in a kind of a dormant level oncology chapter, but still we have a consultant oncologist. But the target of this training program is targeting Kilnochi, Mullaitivu, and Mana, especially extending the training chapter to these 3 districts. So how we are going to initiate, or how can we initiate this chapter? That's what my worries.
I think Dr. Surendra Kumar is having some plans. Over to you, sir.
Dr. Suren is muted.
Yeah. Can you? I missed the last part. What did you ask, Viduran?
No, his question is how he can, how we are going to utilize. Now they are going to get a training, no? Then after that, how we are going to utilize it? That means the practicing.
Yeah, utilize them as actually like what Madragan and Hausigan is doing. I don't know. Viduran, where are you working at the moment?
I'm in DGH Mullathil, sir.
Okay, so then DGH Mullathil, and we want to have it from the DGH Mullathil that as Nisahan mentioned and already started now 2 beds thing, no, the palliation. So we need to kind of follow the strategic management plan developed by the Cancer Control and the Ministry of Health. So then we can have a hospital, and also we have to have a clinic in the hospital. So then you can get all the referrals from these various units for you to work with one consultant. Now then where we need to find out a focal point that maybe the one of the physicians to support you. Now that Madura is supported by the oncologist in Vaunia and Pausian is guided by the oncologist in Kallipala Hospital. So the strategic document also telling like that. So you have to work with one of the specialists who is working there that who can help, but that we will actually provincial health ministry will liaise with you, them, and then you can start your clinics with the support of the director of the hospital. So then also we need to run the home-based care thing that again we are looking for the support at the moment. I mentioned Canada is supporting to Vaunia and Jaffna. So then we also we will get that support, and you should be able to operate at, in your availability, the free time, 2 to 3 days in a week to go to the field and with your nursing team to do the service. So that's why that now we are planning. Then when we get things, and we will see this will evolve because based on the your commitment and the team's commitment and the resources. So that's all thing. But some other way until we get no, then again Nisahan said that we have 2 community nurses, one Mullathil and another one Vaunia. But then we are expecting more and more community nurses in future. So if we can get more community nurses, then we may be able. So that all depends on the resources and things. But at the moment, our plan is this. But we will discuss this in later in the case discussion and thing. Because after having a couple of case discussion, also you will get the idea. Now only you will know then what are the difficulties and issues that patients are facing and how they need to be managed. So then with that, we can think about more.
If I may jump here and give you a brief comment.
You're very quiet, Vera.
Oh, sorry. Can you hear me now?
It's very low, sir. Your volume is very low.
Very quiet.
So maybe this is my fault. Okay. Is it clear now? Sorry.
It's still pretty quiet, but
Okay. Is it clear now?
just you're clear, but very quiet.
Oh. When we all started this,
there we go. Perfect.
advocating the government, the provincial government and the central governments, and they promised us they will take over the whole palliative care in 3 years. That is, they said last year. So there is good news coming up, and we have to show that this is working. And I think Madurahan and Gaushigan has already shown great. We have lots of numbers to give them. And eventually, I think once the COVID is over, the provincial government will eventually take over and appoint permanent cadres for palliative care exclusively. Because right now, Madurahan is working in cardiology department and he's doing palliative after hours. Gaushigan is working in the at the oncology, Tellipalai, and he's working as partner. There is no recognized cadre now, but wait and watch. We will advocate, continue to advocate.
Those are all very good points and very good questions. Thanks, Dr. Vatharhan, for bringing that forward. And it's something that is going to take a lot of planning moving forward. I will say having Dr. Keitheswaran involved in a lot of this over the years has just been amazing to have his buy-in, and he's been attending a lot of the meetings, and I don't know where he finds the time for all of this, but he's been very, very supportive. And I'll say the Two Worlds Cancer Collaboration, they've done a lot of palliative care development in several other countries in South Asia and Nepal and Bangladesh and India and things like that. And everybody has their own challenges, but the government and administrative involvement in Sri Lanka has been very, very encouraging and very active along the way. So I think that's a huge positive and something that we can build on, but it's not without very significant challenges, and particularly just the general limitations around physician and nurses numbers that you are faced with. So we'll have to keep working with those things, but it's very encouraging to see many people in leadership seeing the importance of this. So I think we should probably close off the session here. We've already gone a little bit over time. We started a little bit late, but I think that's really great discussion around a lot of different topics, from fentanyl patches to ethics to program planning. So that's a lot to pack into 1 hour. And we will reconvene next week. Gaushigan will present his case, and we can have some further conversation then. I'll just mention too, we'll try to also send out, we'll get Krishna to send this out, just a spreadsheet so that we can get a bit more of a formalized schedule over the next few months around who will be presenting when. So I think next week we can try to have Gaushigan present. The week after, I'll try to get Dr. Mathurahan from Vavaniya to present. And then maybe after that, we can get some case presentations from some of the other districts, from some of the other participants. And I realize you're not doing necessarily formal palliative care practice, but I'm sure you're seeing patients that have palliative care needs and that you may have questions about, or patients that you feel like could be followed by a palliative care team. So those types of patients, and realizing that their needs are not being met adequately, would be good to discuss how we can support them better. So we'll send out that spreadsheet to start making the schedule a little bit more clear. But otherwise, we will plan to meet up again next week. Not sure if I'll be available this time next week, but we'll try to find at least some other faculty to make sure that we can help facilitate things. So
next
great.
week, are we going to do only one case presentation by Dr.
Yeah,
Gaushigan?
I think let's just do one by Dr. Gaushigan, and there seems to be more than enough to talk about. So
yeah,
Sure.
one case is enough. Yeah.
yeah.
Thank you, sir. So, thank you so much. I know, we have exceeded time. So, thank you so much for your patience, and that's wonderful discussion and the session, the case presentation by Nisahan, sir. And we'll all see you. Please, we have shared the feedback link in the chat box. We request you to please, all the participants, to kindly click on the link and kindly share your feedback. I'll be sharing the recorded YouTube session maybe by tomorrow or day after to the playlist. And our next session will be on September 29th, again Wednesday from 8 p.m. So we have our faculty ready, the case presenter ready, Dr. Gaushigan, for our next session. Thank you so much and have a good evening. Thank you, one and all.